Thanks for visiting our YouTube channel. We bring the most important topics with the current evidence every Sunday at 6:30 a.m. Central Time, United States, and 6 p.m. Indian Standard Time. This particular seminar discusses about status epilepticus. We discuss pediatrics, adult, and pregnant women. First, definitions. Early status epilepticus refers to a seizure lasting longer than 5 minutes. Established status epilepticus, where the seizure persisting longer than 5 minutes despite treatment with benzodiazepines. Refractory status epilepticus, where the prolonged seizure that has not responded to 2 doses of different anti-seizure medications. Super refractory status epilepticus, where seizures lasting more than 24 hours. Another way of differentiating status epilepticus, one is convulsive status epilepticus, wherein the seizure has tonic-clonic movements which involve either focally or generalized. This is the most common and most life-threatening. Another one, focal status epilepticus, again divided into 2 groups: without impaired awareness, with impaired awareness. When it is with impaired awareness, that is called complex partial status. When it is without impaired awareness, that is either called focal motor seizures. Previously, it used to be called simple partial status. For focal status and absent status, the different yardsticks used. When it lasts longer than 10 minutes, it is called status epilepticus. Complex febrile seizures, where the seizure lasts longer than 15 minutes, occur multiple times in 24 hours. They can have focal seizures. It's often seen in children between 6 months to 6 years old. We are not discussing neonatal seizure in this particular seminar because they have different etiologies and unique pathophysiologic mechanisms. Non-convulsive status epilepticus, wherein they can have focal motor seizures, non-motor seizures, or absent seizures. Pathogenesis. Status epilepticus occurs because failure of inhibitory pathways mediated by GABA and hyperactivity in excitatory pathways mediated by glutamate. It leads to neuronal damage, cell death, and alteration in brain networks. Seizures lasting longer than 30 minutes represent the beginning of neuronal damage with self-perpetuating dysregulation. The prolonged seizure leads to internalization of GABA subunit A receptors, reducing synaptic inhibition as well as responsiveness of benzodiazepines. So giving more number of benzodiazepines does not cessate the ongoing seizures because of internalization of A subunit of GABA receptors. Status epilepticus leads to increased epinephrine and norepinephrine levels, promoting peripheral vasoconstriction to enhanced continued perfusion and oxygenation of the muscles and brain. It causes cyanosis and decreased oxygen saturation. The longer the seizure continues, it increases the risk of compensatory failure, resulting in decreased perfusion, oxygenation, and glycemia. High rate of decompensation with the cardiovascular happens when the seizure lasts 20 to 40 minutes. The convulsive status epilepticus can be confused with psychogenic non-epileptic seizures. They will have a fluctuating course, retain awareness despite bilateral convulsive activity, asynchronous movements, forced eye closure, lack of labored breathing postictally, and a return to baseline function. EEG distinguishes epilepsy from non-epileptic events. The helpful features distinguishes epilepsy from dissociative seizures or seizures often last more than 5 minutes, fluctuating course, that means waxing and waning, asynchronous rhythmic movements, pelvic thrusting, side-to-side body movements during a convulsion, closed eyes, ictal crying, recall of items during the event. Even things like tongue biting, having incontinence, gradual onset, non-stereotyped flailing and thrashing movements, opisthotonus, and associated injuries does not preclude as epilepsy. It could be still non-epileptic event. As I mentioned earlier, it needs to be EEG is the way to differentiate from epilepsy from non-epileptic event. Another thing that we need to distinguish is status dystonicus. It's a rare, potentially life-threatening condition that can be mistaken for status epilepticus. The non-convulsive status epilepticus can present as altered mental status, meaning persistent hallucinations, confusion, coma. They can have motor phenomena like automatisms, ataxia, dysarthria, autonomic changes like pallor and vomiting, and history of epilepsy or convulsive status epilepticus. Non-convulsive status epilepticus is associated with neuronal injury and increased morbidity even without clinical seizures. So non-convulsive status epilepticus is also an emergency, need to be treated the same way what we will do in convulsive status epilepticus. The incidence of status epilepticus is 10 to 58 per 100,000 per year. The highest incidence of refractory status epilepticus occurs in children younger than 1 year. And the male to female ratio is 1.2 to 2 to 1. So there is a male predominance. There is no consistent difference by race or socioeconomic status have been reported in pediatric status. The etiology of status epilepticus are grouped into 6 different categories. It could be acute symptomatic, remote symptomatic with acute precipitant, progressive encephalopathy, febrile status epilepticus, and cryptogenic or idiopathic. Acute symptomatic comprises 26% of total status epilepticus, caused by meningitis, encephalitis, electrolyte disturbances, sepsis, hypoxia, or intoxication. Remote symptomatic happens in patients who had a previous CNS injury. It constitutes 33% of total status epilepticus. Remote symptomatic with acute precipitant, such as previous CNS injury patients having a concurrent exacerbating factors such as illness or hypoglycemia. It constitutes 1% of the total status. Progressive encephalopathy, children with underlying progressive disorder, happens in 3% of statuses. And febrile status epilepticus comprises 35% of status epilepticus, and cryptogenic or unknown reason in 15%. Electroclinical syndromes like Lennox-Gastaut syndrome can present as status epilepticus in 10% of the children. 25% of the children with epilepsy develop status during their lifetime. Now, how to prevent status? As a rule, seizure is easier to stop soon after it begins than after it has become persistent. And halting the seizure earlier should mitigate the adverse physiologic effects of prolonged seizures. So it's important to abort seizure before it becomes status. How to abort? There are 5 different medicines available: intranasal diazepam, rectal diazepam, intranasal midazolam, and oral dissolving tablets of clonazepam and buccal midazolam. The doses are given in this table. Rectal, the diazepam can be given rectally. It's available as a diastate. The doses are given here in different age groups. This is approved for children aged more than 2 years. Diazepam nasal spray, it is approved for children more than 6 years of age. Midazolam buccal administration, it is often used in hospital settings because it's available 0.3 to 0.5 milligram per kilogram, max of 10 milligram. Midas nasal spray, it's recently available. Initial dose is 5 milligram, second dose 5 milligram administered after 10 minutes of patient has not responded to the initial dose. The maximum dose is 10 milligram. It is approved for patients more than 12 years of age. Clonazepam is a dissolving tablets, can be used 0.01 to 0.02 milligram per kilogram. It is off-label use. The issues with the rescue medications, we need to teach the caregivers. Oftentimes these medications are given at home. So this most common side effect of these medications is sedation, and it can cause respiratory depression, especially when the patient takes along with opioids, barbiturates, and alcohol, especially in older pediatric patients. This is important trial done intramuscular midas versus intravenous lorazepam in pre-hospital status epilepticus. That's often called RAMP trial, otherwise rapid anticonvulsant medication prior to arrival trial. It is a randomized double-blind phase 3 non-inferiority clinical trial. The dose used in patients 13 to 40 kilogram, 5 milligram intramuscular midas or 2 milligram IV lorazepam. If the weight is more than 40 kilogram, 10 milligram intramuscular midas or 4 milligram IV lorazepam. What they identify is intramuscular midazolam is as good as intravenous lorazepam. The p-value is less than 0.001. So in the absence of IV, the midazolam was as good as IV lorazepam. So how to manage status? Adequate airway, breathing, circulation, and suction of secretions or vomitus, medication for prolonged seizures, and monitoring of vital signs, including saturation, blood pressure, and heart rate. So early IV access is very important. If there is a delay, either you will have an intraosseous line or give intramuscular midas. If the weight is 13 to 40 kilograms, 5 milligram. If it is more than 40, 10 milligram intramuscular. Get the lab evaluation done, especially glucose, basic metabolic profile, calcium, complete blood count, and anti-seizure medication levels if it is appropriate. And identify the treatable causes of seizures such as hypoglycemia, hyponatremia, and hypocalcemia. In appropriate patients, get the urine toxicology, other metabolic studies, and if it is available, get the EEG hooked up right away. And neuroimaging oftentimes happens after the seizure being controlled, and antimicrobial if you suspect meningitis. It should not wait the test results. Give antibiotic as soon as you suspect CNS infection. Leukocytosis could suggest the underlying infectious etiology, and check for subtherapeutic levels of anti-seizure medications, and as we mentioned earlier, urine and serum toxicology. To recap the labs: complete blood count, serum electrolytes, serum glucose, anti-seizure medication level, serum and urine toxicology, lumbar puncture, neuroimaging, electroencephalogram. The two important points: abort the seizure as quick as possible before it becomes status. Give antibiotics even when the tests are not available. This slide talks about initial evaluation and management. of confirmed or suspected status epilepticus. The most important, assess airway, breathing, and circulation. Obtain IV access, check blood glucose. If it is low, less than 60, go ahead and treat with D50 in adults. In children, appropriate D10 or D25. Do the neuro exam and score the stroke index. If the stroke score is more than 4, activate the stroke team. The seizure lasts more than 5 minutes. Give IV lorazepam 0.1 per kilo, max of 4 milligram. If the seizure doesn't abort in the next 5 minutes, give the second dose at that point. Give the second line anti-seizure medication such as levetiracetam 60 per kilo, max of 4.5, or IV fosphenytoin 20 per kilo, max of 2.5, IV valproic acid 20 to 40 milligram per kilogram, max of 3, IV lacosamide 4 to 6 milligram per kilogram, max of 400 milligram, IV phenobarb 20 per kilo, max of 2.5 gram. During this time, reassess airway, breathing, circulation, and EEG need to be hooked up. Get the CT scan once the seizure is under control, and get the CT angiogram and CT perfusion as recommended by the stroke team. And antibiotic, antivirals, and adjunctive agents needs to be done during this time. If the seizure still continues, check whether the patient is responsive or unresponsive. If the patient is responsive, having non-convulsive or focal, load second dose of anti-seizure medication. It could be levetiracetam, fosphenytoin, valproate, lacosamide, or phenobarbital. If the patient is unresponsive, you need to start anesthetic medication such as propofol 1 to 2 milligram per kilogram bolus, followed by 20 to 300 mics per kg per minute, or midas 0.2 milligram per kilogram, followed by 0.05 to 2 milligram per kg per hour, or ketamine 2 milligram per kilo, followed by 2 to 4 milligram per kg per hour. During this time, again, reassess airway, breathing, and circulation, EEG, and follow the stroke team orders, and also involve neurointensivist by this time. If the patient is still seizing, then discuss with attending and transfer the patient's neurocritical care ICU and start him or start her on pentobarbital 10 to 20 milligram per kilo plus 0.5 to 5 milligram per kg per hour infusion. In addition to what we have discussed, what are the additional items one should consider during the treatment of status epilepticus? Number one, how to choose the anti-seizure medication. Levetiracetam is the first choice. If stocked on the floor, it is available almost all the institutions in the United States. And also, it can be used even when there is an underlying liver disease or pregnancy. Valproate, it is the first choice if there is renal disease, myoclonic status, and absent status. Fosphenytoin is preferred over fosphenytoin because of less infusion-associated hypotension. Avoid the combination of valproate and fosphenytoin. And one should be aware of acute adverse drug effects. Fosphenytoin can cause hypotension, cardiac arrhythmias, and somnolence. Valproate can cause hyperammonemia, hepatotoxicity, thrombocytopenia, and teratogenic. Lacosamide can cause AV block, bradycardia, and hypertension. Empiric antibiotics, antivirals, and adjunctive agents needs to be given when there is a suspicion of meningitis or encephalitis. The dose recommended, vancomycin 25 per kilo, max of 2.5, ceftriaxone 2 gram, acyclovir 10 milligram per kilogram, ampicillin 2 gram. If the patient is more than 50-year-old or immunocompromised, to cover for listeria. Penicillin allergic patients, Bactrim 5 per kilo, IV plus aztreonam 2 gram IV, 1 dose. Pyridoxine is given with a dose of 25 per kilo, max 5 gram. If isoniazid toxicity suspected, 1 gram per 1 gram per 1 gram per 1 gram of isoniazid ingested. Time in dose 100 to 500 milligram IV. During this time, history and past medical history and thorough examinations need to be done. Discuss with senior resident or other senior attendings. Review the CT head, CT angiogram, and follow with the stroke team. Continuous EEG needs to be ordered and checked with neurologist. When you do the spinal tap, draw at least 10 ml of spinal fluid. We consider sending for cells, protein, glucose, bacterial culture, and fungal culture. And make sure you do for meningitis panel that often involves herpes, varicella zoster, Epstein-Barr, and CMV. In certain cases, autoimmune panel needs to be sent. Does speed really matter? Age and etiology of status are the biggest determinants of the outcome. Achieving seizure control within the first 1 to 2 hours of onset is a significant determinant of outcome. So very important to identify and treat and abort the seizure as quickly as possible. The initial medications for prolonged seizures are midas, diazepam, and lorazepam. All the 3 drugs can be given intravenously. Midas and diazepam have intranasal formulations. Diazepam has a rectal formulation. Midas can also be given intramuscularly. All medications can be given intraosseously. So the best way to abort, if there is an IV, go ahead and give lorazepam. In the non-availability, give intramuscular Midas. If the access is difficult, get intraosseous access and give those medications as discussed before. So when there is an intravenous access, the drug of choice is lorazepam, 0.1 per kilo, the max of 4 milligram. It can be repeated 1 time if the seizure does not stop in 5 minutes. Diazepam dose is 0.15 to 2 milligram per kilogram, max of 10. It has a rapid onset of action, well-established treatment option, risk of drug accumulation in repeated doses. Clonazepam, 0.015 milligram per kilogram, max of 1 milligram. In the absence of IV, intramuscular Midas can be given. If the weight is 13 to 40 kilos, give 5 milligram. If it is more than 40 kilos, 10 milligram. Diazepam 10 milligram rectal can be given. Lorazepam intranasal 4 milligram. The dose is 0.1 per kilo, 1 milligram per kilogram if the weight is less than 40 kilos. So when to give the second dose of medication, the first dose of benzo needs to be given within 5 minutes. If the seizure fails to stop within 5 minutes, the second dose of benzo needs to be given. Because of the short duration of action of benzos, second-line medication is often administered even if the initial drug successfully halted the seizure. The second-line medications are levetiracetam, fosphenytoin, and valproic acid. If levetiracetam fails to halt the seizure, fosphenytoin, then valproic acid can be added. Phenobarbital is a reasonable alternative if levetiracetam, fosphenytoin, and valproic acid are unavailable or ineffective. Lacosamide can be given intravenous, generally well tolerated. There are data to support the efficacy in status, at least in adults and also in adolescents. As we mentioned earlier, the dose of FOS 20 per kilo up to 1.5, levetiracetam 60 per kilo up to 4.5, phenobarb 20 per kilo up to 1, valproate 20 to 40 per kilo up to 3 grams. We are going to discuss three trials to determine which anti-seizure medications need to be given after the initial benzos. One is concept trial. It is open label, multi-center, randomized control trial done in Australia and New Zealand. Children aged 3 months to 16 years were investigated. There were two arms. The one arm received 20 milligram per kilogram of phenytoin, intravenous or intraosseous infusion over 20 minutes. Second arm is 40 milligram per kilogram of levetiracetam, intravenous intraosseous infusion over 5 minutes. They checked the clinical cessation of seizure activity in 5 minutes. And there were subgroup analysis was done, children less than 5 years, more than 5 years, and another analysis whether it is focal onset, generalized onset. Another subgroup was febrile or afebrile, and subgroup analysis based on midazolam of first line versus the lorazepam. They found there is no difference between phenytoin group and levetiracetam. Another endpoint at 2 hours was done in both the groups, whether the seizures stopped at 2 hours. Again, there were no difference. And also they evaluated intensive care unit admission, length of hospitalization in ICU, and median length of hospital admission total. Again, there were no difference between these two groups. Follow-up was done 1 month and 2 months after discharge. Again, there were no difference between these two groups. The side effects were monitored. There were no difference between these two groups. The concept trial concludes levetiracetam is not superior to phenytoin for second-line management of pediatric convulsive status epilepticus. The second trial is Eclipse trial. It was done in UK emergency departments at secondary and tertiary care centers. Again, it's open label randomized clinical trial. The participants 6 months to 18 years. Again, there were two arms. One arm received levetiracetam 40 per kilo over 5 minutes. Another arm received phenytoin 20 per kilo over 20 minutes. And both the demographics between these two groups are comparable. And the secondary outcomes and 14-day follow-up between these two groups, again, non-significant. And trial adherence between these two groups, again, comparable. And side effects are insignificant between these two groups. So interpretation of Eclipse trial, levetiracetam was not significantly superior to phenytoin. The results, together with previously reported safety profiles and comparative ease of administration of levetiracetam, suggest levetiracetam could be an appropriate alternative to phenytoin as the first choice of second-line anticonvulsants after the benzo failure. Number one, levetiracetam is easily available. Number two, it can be infused over 5 minutes when compared to phenytoin, needs to be given over 20 minutes. Third one, called Seizure trial. Here it is a little different. This was investigated in children, adults, and older adults. The other difference is it compared the efficacy of levetiracetam, fosphenytoin, and valproate. There were 3 drugs were evaluated. In children, there were no significant difference among these 3 drugs. In adults, same. But in older adults, there is valproate performed much better than fosphenytoin and levetiracetam. But overall effect among these 3 is no significant difference between all the 3 as far as efficacy goes. The interpretation of Seizure trial, any of the 3 drugs can be considered as a potential first choice for the second line benzodiazepine refractory status epilepticus. Again, because the ease of use, the ease of availability, levetiracetam is widely used at the dose of 60 milligram per kilogram rather than 40 milligram per kilogram that was done in all those 3 trials. If the seizure persists after the second dose of anti-seizure medication, then one should consider continuous infusion of midas, pentobarb, or ketamine. Neuroconsult needs to be obtained, EEG monitoring needs to be done. There is no consensus on which third-line infusion should be used. But one should remember, midas and pentobarb require secure airway. Midas and pentobarb infusion can induce significant hypotension. Be prepared to give fluid boluses and have vasopressors ready. Ketamine has less effect on blood pressure and does not require intubation. Propofol infusion rarely used in pediatric patients due to the risk of propofol infusion syndrome. The additional treatments such as refractory, such as ketogenic diet, corticosteroids, and the IV immunoglobulin and vagus nerve stimulation needs to be considered if the seizure persists with the anesthetic medications and the previous anti-seizure medications. So, what are the considerations when you are choosing an anesthetic infusion? Midas has a favorable hemodynamic profile when compared to pentobarb. But one should remember that tachyphylaxis happens if the infusions of midas goes beyond 24 hours. Another important thing to consider, the midas can deposit into adipose and can cause prolonged sedation. Propofol rapid clearance, it may cause dependent hypotension, myocardial depression. The fearsome complication of propofol infusion syndrome or PRES with extended use and in children. Ketamine among all these drugs have a different mode of action. It acts through NMDA blockade. When compared to others, they all act through GABA. There's a favorable hemodynamic profile when compared to others. Unclear half-life in high dose and prolonged infusion. And ketamine is less steady than other sedative medications to control the seizures. And finally, pentobarb. It is often reserved for when other anesthetic medications are not able to control the seizures. It has a prolonged half-life. It can cause cardiac depression, bone marrow suppression, and ileus. At this point, the patient needs to be hooked up with EEG monitoring, and the diagnostic investigations needs to be done. That includes autoimmune panel, look for paraneoplastic panels, especially in adults, and imaging for tumor, and adjunctive treatments like immunosuppression and ketogenic diet, and potential seizure focus, neuroimaging, and neurosurgery involvement needs to be done at this point. Let's switch a gear. Status epilepticus in pregnancy. There are two kinds. Status epilepticus in patients with previous history of epilepsy. The second group is new onset status epilepticus. The new onset status epilepticus in pregnancy caused by 4 entities. 1. The posterior reversible encephalopathy syndrome, otherwise called PRES. Reversible cerebral vasoconstriction syndrome, or CVS. Eclampsia, cortical venous thrombosis. Whether it's new onset status epilepticus in pregnancy, one should consider PRES or CVS, CVT, and eclampsia. Establish a diagnosis and treat accordingly. And there is a status epilepticus in the previous history, with the previous history of seizures. Monitor closely, check ASM levels, exclude other causes, treat according to the guidelines. Consider early delivery or possible termination, especially if the seizure. Let us review status epilepticus in pregnancy, literature review, and protocol proposal. In pregnancy, one should keep in mind their gastric pH is lower, there is a delayed gastric emptying and decreased GI motility, and their blood volume is higher, and their albumin is lower, and other metabolic abnormalities, and there is a faster elimination because of increased renal blood flow. That all needs to be considered when you are using and choosing the medication. There are multiple studies have been published in status epilepticus during pregnancy. Most of them are case reports except two. One is a retrospective study, another one is prospective study that was done in 2016 and 2017. What is alarming is in retrospective study, almost 30% of the pregnant women died. And the prospective study, almost again 27% had a poor neurologic outcome. So it's very imperative to have a protocol to control the seizure in a timely fashion. In addition to the physiologic variables we discussed earlier, one should understand the medication such as diazepam, lorazepam, midas, and clonazepam, MAG, the second line medications and third line medications in pregnant patients, how the pharmacokinetics differ. There is lots of information available in this particular review published in 2022. Status epilepticus in eclampsia. The drug of choice is max sulfate. The loading dose of 4 gram or 6 gram over 15 to 20 minutes, followed by maintenance 2 gram per hour. If the seizure persists, use one of the benzos with lorazepam, diazepam, or midas at the recommended dosages. If the seizure still persists, one should start midas, propofol, thiopentol, or ketamine infusion. Induction of labor is indicated if fetal maternal condition are stable. Cesarean delivery is recommended if maternal and fetal status are not reassuring. Second bolus of IV MAG 2 gram can be given if the seizure persists. The status epilepticus outside eclampsia happen in pregnancy. One should follow the first line medications like benzos as recommended for adults, midas, lorazepam, and diazepam. If the seizure persists more than 5 minutes, then use the second line medication levetiracetam 60 per kilo, fosphenytoin 20 per kilo. If it still persists, one should consider using midas, propofol, thiopentol, and ketamine. Termination of pregnancy via delivery or abortion is recommended if the prolonged exposure to multiple anti-epileptic strategies is not able to solve status epilepticus. Let's look at the clinician survey, which medications most of the physicians use during pregnancy. In this particular survey, to the question of which second-line anti-seizure medication would you choose in pregnancy, 87% of respondents gave levetiracetam. What is the next line of medication would you choose? 60% showed lacosamide and 20% said fosphenytoin or phenytoin. Which anesthetic agents you will use in refractory status epilepticus? Most of the respondents, like 60%, said midas. Another 36 used propofol. So in total, 96% use either midas or propofol. Outcome after status epilepticus. 2.7 to 5.2% of patients with status epilepticus die during acute hospitalization. Long-term mortality after hospitalization can increase from 3.8 to 17%. Outcome depends on the duration of seizure and the underlying etiology. Some causes of status epilepticus have high mortality and high morbidity rates, independent of the seizure, such as near drowning, sepsis, hemorrhagic shock, aspiration, and prolonged mechanic ventilation. Those patients who had seizure in those particular settings have a high morbidity and mortality. Refractory status epilepticus increased mortality to 32%. Neurologic sequelae such as motor deficits, behavior and developmental problems, and new onset epilepsy can happen as sequelae to status epilepticus. Recurrent seizure ranges from 16 to 50%. It can lead to focal deficit, behavioral disorder, and cognitive disorder. 1/3 of the patients will develop cognitive and behavioral problems after status. Younger age at onset and duration of status are the strongest predictors of worst neurocognitive outcomes. So it's very imperative for pediatricians and family practitioners to halt the seizures as quick as possible. And after the discharge, close monitoring of patient development, behavior, and cognitive ability by both the neurologist and the pediatrician after status is essential. So take-home points. Status epilepticus is a neurologic emergency. So timely intervention prevents seizures becoming status. Check glucose, calcium, and serum sodium. Do not forget the diagnosis of meningitis. And if the meningitis is suspected, do not delay antibiotics. Go ahead and give the antibiotics even without any test result. Control the seizure within 30 to 60 minutes. Get neurologic consult. Get appropriate neuroimaging in appropriate time. And continuous EEG for status is a must. This concludes seminar on status epilepticus in adults, children, and in pregnant women. We bring in the important medical topics with current evidence every Sunday at 6:30 a.m. Central Time, 6 p.m. Indian Standard Time. If you like it, please like us, share with medical students, practitioners, postgraduate students, teachers, and everyone who are interested in this topic. Thank you for watching.